continuing chapter 28, talking about head and spine injuries. So, a brain contusion is kind of the worst aspect of a concussion. So, a concussion is less serious, a contusion is more serious. It can be far more serious because it now involves physical injury to the brain tissue rather than just a bump and kind of increasing pain, pressure, etc. This literally damages into the tissue. So the patient may have long-lasting, sometimes even permanent damage because of this. And a patient who has sustained a brain contusion may exhibit any or all signs of brain injuries. It just kind of depends on where and how bad it was. Other brain injuries, they can arise from several different factors. It can be medical conditions. So if you get a blood clot or a hemorrhage leading to a stroke, can be because of problems with blood vessels, such as high blood pressure, other problems that can cause spontaneous bleeding in the brain. You can have infections, hypoxia that lead to brain injuries as well. Signs and symptoms of non-traumatic brain injuries, they're often very similar to those of TBIs, but they just have a different cause. Spinal injuries, the cervical, thoracic, and lumbar portions of the spine can be injured in a huge variety of ways. Compression injuries result from a fall or direct blow to the crown of the skull, so up on the top of the head. The coccyx or the tailbone, or it can be that they jump from a height and land on their feet. That actually can push up all of that pressure into the low back, particularly. This is any force that compresses the vertebral column, can lead to herniation of discs, subsequent compression on the spinal cord or nerve roots, and then bone fragmentation into the spinal canal, causing further injury. Motor vehicle crashes, any other type of trauma that can overextend or hyperflex the cervical spine can easily damage ligaments and joints there, since your cervical spine has the most free movement out of the rest of your spine. Rotation flexion injuries of the spine result from rapid accelerative forces. So more so if you were standing still or stopped at a stoplight and somebody were to hit you, that rapid acceleration definitely can cause some injuries. When the spine is pulled along its length, such as hyperextension, it can also cause fractures of the spine as well as injuries to ligament and muscle injuries. You see this in like hangings, unfortunately. When the bones of the spine are altered because of traumatic forces, it's very likely that they can fracture or move out of place. That's why we always keep a high index of suspicion for spine and neck traumas with or injuries with any sort of trauma, because truly it can take a lot of force, but you never quite know. So what our position has been, and that is changing, and I'm hoping that the discussion question for next week kind of gets you thinking along that lines, but it always has been err on the side of caution. Everybody that has an MOI that could be contiguous with a spinal trauma or C-spine trauma, put them on a board. So that is shifting, but it hasn't yet. So keep going with that, or follow your local protocols depending on that. But any unnatural motion can cause fractures, which can then result in neurologic deficit. Our spine is not meant to move a lot. It's got some give to it, it's got some flex to it to allow us to move around, but it's not supposed to do a whole lot, unfortunately. For patient assessment, always suspect possible head or spinal trauma whenever you see a patient with any of the listed mechanisms of injury. Keep in mind with the fall, for an adult, it's usually greater than 20 feet. Pediatric is greater than 10 feet or 2 times the patient's height. There are a couple more here on this next page. So rapid deceleration, hangings, axial loading injuries, which is where a load is actually applied to the spine, either along the vertical or longitudinal axis. So this could be falling from a height and landing on your feet in an upright position, which we already did talk about a little bit, and then diving accidents as well. For C and size up, not a whole lot has changed here. We are definitely looking at indicators for mechanism of injury and trying to decide if the patient has potential for head or spine trauma. Primary assessment, again, life-threatening conditions are your main focus during the primary assessment. You want to take care of any sort of issue or threat to airway, breathing, circulation. And then you want to try and reduce your on-scene time in order to increase the patient's chance of getting out of this with no neurologic deficits. So we're not going to be able to do much for them on scene. We've got to get them to definitive care. For spinal immobilization considerations, you definitely want to be aware of how the patient was positioned and how are you going to get to that patient. Oftentimes we can make unnecessary movements when we're trying to get our patient to a point where we can spinally immobilize them, and that's definitely not doing anything much better for him. If your patient is ANO times 4, does not have any neurologic deficits, no spinal pain or tenderness, no evidence of intoxication or other illness, and no injuries that may mask a spinal injury. If they have a severely angulated arm, that's a distractor. So I would not go with that, but you may consider not placing them in spinal restriction. Again, that's going to be based on your local protocols and what your service allows. Otherwise, we're going to go ahead and put them on a backboard, which good and bad. Yes, it does protect the spine from additional movement, but the patient is not anatomically stable on that. It doesn't accommodate for the curvatures of the spine and pressure points. And so it can actually cause more damage than good if they're on there for a long period of time. So if you have an extended transport, you may need to get creative with the best way to transport your patient. C-collars, they, once placed on, you don't move them, but these are not the end all to be all when you're talking about keeping a head from moving. With a cervical collar on, yeah, it's uncomfortable, but if you really wanted to, you can move your head around. So this is just think of it more of as a reminder tool for the patient to not move their head. Say, this is going to keep your neck more stable, but it's also a reminder for you not to move your head, because if you move your head, even with this on, you can cause injury to your neck. And then if you need to remove it, you need to maintain manual stabilization until you can put that back on. Oftentimes we don't release manual stabilization until we have the head secured to the board. Sometimes it is appropriate to just place a C-collar and not put them on the board. Again, make sure that you're following your local protocols. For looking for signs and symptoms of head injury or spine injury specific, you need to ask a couple of extra questions. And oftentimes, it's really not going to be different from what you're going to ask most people. So what happened? Where does it hurt? Specifically, does your neck or back hurt? Can you move your hands and feet? Did you hit your head? Was there a loss of consciousness? And you'll find that more often than not, people will say, no, I didn't have a loss of consciousness. And then you say, okay, well, do you remember the cars actually colliding? Do you remember actually hitting the ground? Do you remember, what's the last thing that you remember before you started talking to me? And oftentimes they can't fill in that gap of time. So that's a little more indicative of the fact that they may have had a loss of consciousness, but they just didn't put two and two together to say, yeah, I definitely did. Any sort of confused or slurred speech, repetitive questioning, or amnesia in responsive patients are a very good indicator of a head injury. People do what's called resetting when they get a head injury sometimes. You'll have this whole conversation with them. They'll kind of go quiet, and then they will ask questions that they've already started with. And the faster that they reset, generally, now this is not a hard and fast rule, but generally the faster they reset, the more severe the injury is. If somebody goes 10 minutes before they reset all the way back to, hey, wait, what happened? Where am I? What am I doing? That tends to be not as bad. If they ask two questions and then reset and re-ask those two questions and reset and re-ask those two questions, that's generally more indicative of a more severe injury. When a patient has any signs and symptoms, MOI, that is along the lines of trauma, you want to make sure that you look at their blood sugar. You can sometimes decide that it might be a glucose injury. So oftentimes with patients that are exhibiting signs of head trauma, we do check a blood sugar because it can mimic those symptoms, but it's always best to assume your patient has that head injury until you actually completely prove otherwise. And even so, a patient with low blood sugar could still have a head injury. That doesn't prove this, that, or the other. But patients that have head injuries that have low blood sugar and low amounts of oxygen actually have worse outcomes. So any patient that has head trauma, you should go ahead and check a sugar on. Any unresponsive patient, you just assume that they have a spinal injury. If they're unresponsive, they're going on a board. They've bought themselves a board. Those with a decreased level of responsiveness should be considered to have a spinal injury, kind of depending on what their chief complaint is and the likelihood based on their MOI. Airway, breathing, and circulation considerations. If you suspect a head injury or neck injury, we're not going to use the head tilt chin lift because we don't want to manipulate that spine anymore. So we're going to use the jaw thrust maneuver to open the airway. If you absolutely cannot open the airway with the jaw thrust, and that's the only way to open or check the airway, and you can't control the airway without it, it's always life before limb. So if you have to, you can do a head tilt chin lift, but you should always start with the jaw thrust. Any patient that has a head injury, vomiting is a regular occurrence. So keep that in mind. Irregular breathing may result because of increased pressure on the brain, so that gives you a little bit more of an idea of what's going on. We definitely try to administer high flow oxygen because it's indicated. We don't want to get them hypoxic, like I was just talking about. A pulse that is too slow can indicate a very, very serious condition. We talk about Cushing's triad. Once they start having that low pulse rate, that's pretty scary. Any single episode of hypoperfusion can lead to significant brain damage and even death. So you may need to get ALS going. We definitely don't want pulse ox values to fall below 90%. We want to make sure we try and keep them at 95 or higher. But we don't want to go the other direction and hyperventilate. That's an option, but it can increase the severity of head injuries. So it should be avoided except where there's cases of herniation, and you should have ALS rolling on that. Manner of transport, if they've got severe issues, something with A, B, or C, they need to be transported, but lights and sirens certainly could increase their anxiety. If the patient is supine, the head should be elevated 30 degrees if possible to help reduce intracranial pressure if you suspect it, but be very cognizant of how you're transporting.